All right, good morning, everybody. Welcome to Grand Rounds. I've got 7 o'clock on the devices here. Just real briefly, for Grand Rounds this morning, following Dr. Lee's presentation, we're going to stay on this WebEx for unknown conference, so we're not going to switch from one to another. And yeah, so this morning our speaker is Dr. Lee. Very brief introduction here for you, Brian. Dr. Lee is an associate professor here in our department and went to medical school at Stanford University, followed by his residency at Northwestern, and then completed a fellowship at Johns Hopkins Brady Institute in sexual medicine and reconstruction. And this morning, he'll be presenting to us about ureteral trauma. And thank you in advance, Dr. Lee, as well, for your time later with the residents during rec. So with that being said, the floor is yours.
Great, thank you. Can everybody hear me all right?
And, yep, all right. Sounding good.
Okay, let me share the screen here. How's that looking? Maybe, Dan, give me a thumbs up. Okay, perfect. All right, great. Well, thank you for that introduction, Dr. Williams. I'll be talking about the management of a ureteral injury. I did trade this topic with Dr. Grimes, so I did use some of his slides, so I want to credit him for some of those, as he did a good talk on it a couple years back. Disclosures. I have this medical device company that I founded, but none of those are relevant to the current topic. So let's start with our CME objectives. So today we'll talk about the ureteral anatomy and physiology related to understanding ureteral injury and stricture disease, the process of healing, interventions, management options, and challenges in the future. So I think, whenever we talk about anatomy, we always start with the embryology, as that really determines, the location of the structures in relation to each other. And I won't go, too much into it, but remember that the ureteric bud induces the formation of the kidneys through the metanephric blastema. And you can see in kind of orange here the course of the ureter and how it relates to the formation of other pelvic and abdominal structures. The ureter is responsible for transportation of urine from the kidney to the bladder. And when we talk about injury and trauma to the ureter, ultimately it's the dynamic and urodynamic effects in terms of impairment of drainage that force us to do something about it. And we'll talk about the stages of intervention healing. So let's start with the surgeon's view of the ureter. So just some anatomic pictures showing the course of the ureter. A bunch of urologists here, so we're all very familiar with that. But this just to highlight that in the picture to the right here, you see in kind of female anatomy and gynecologic surgery that the ureter passes in very close proximity to other structures because of its kind of tubular appearance. It can appear similar to vascular structures. And for anyone who's ever operated on the ureter, the most challenging part of the operation oftentimes is really just getting to the ureter, step one, and identifying and mobilizing the ureter safely. And while this is, a nice kind of netter like images with things color coded, here's a picture of how, ureters tend to look on a cadaver. Everything looks the same. There's about similar caliber structures, etc. And so I'll make, multiple papers and stuff will refer to different parts of the ureter. And this, just so that we're all on the same page, especially the, maybe more the trainees, that they'll refer to kind of the upper ureter, the mid ureter, and the lower ureter. The upper ureter typically refers to the portion above the pelvic rim up to the level of the UPJ. The middle ureter typically refers to this section overlying the bony pelvis, and the lower ureter is a section below the bony pelvis. Now, that isn't the only way of describing different parts of the ureter. Some will refer to the abdominal portion of the ureter, which they typically say above the iliac vessels, and the pelvic portion of the ureter. Here they talk about this. This is this Japanese study where they talked about the perirenal portion has more mobility. So there's sections of the ureter that are more mobile. And this study was interesting because they were arguing that the traditional thought that stones get stuck at the level of the UPJ, the iliac vessels, and the intraluminal portion of the ureter may not actually be true, and that this other portion where what they call the crossing point, where the gonadal vessels cross, is actually a more common hang-up point in the passage of things down the ureter. Ureteral anatomy. So the ureter is not a simple tube. It acts as a functional syncytium. This was a cool picture, cool video, which showed a calcium wave passing through the ureter. I tried hard to try all these different ways to get it into the presentation, but I was just able to get a picture. So the idea is that, there is this ureteral peristalsis that happens with this wave-like contraction of excitation, contraction, coupling that kind of moves boluses of urine down the ureter. And the clinical correlate of that is that transection can lead to disruption of this action potential propagation and lead to aperistaltic segments. Layers of the ureter. So just to highlight the different layers of the ureter, where the blood vessels go, etc. So innermost layer is the mucosa, followed by kind of this muscular coat. And there are these perforating arteries. This layer here, which is what we often see right here labeled 3, is the adventitia, this kind of whitish coat of the ureter. That's where this adventitial vascular plexus is really responsible for movement of blood longitudinally along the ureter. And so that is probably the most critical blood supply. However, these small blood vessels that penetrate here listed as 5, that will supply blood from adjacent structures. So as it's crossing over the gonadal veins, the iliac arteries, these actually pass in this ureteral sheath, or here there's a British journal, so they call it the mesoureter over here. So over dissection, really, if you dissect to get to this really glistening white, adventitia, you actually dissected off some of this blood supply. So the clinical correlate of that is you want to avoid skeletonizing the ureter, as a significant amount of blood supply courses between the adventitia and the ureteral sheath, or mesoureter as described here. Blood supply to the ureter. You can see here in this pictures to the right that as the ureter courses down, there are these branches of the vessels. So basically, referring to your knowledge of anatomy, you think of what is the closest arterial blood supply, and that, at least in theory, provides the majority of the blood supply to that section of the ureter. So going from top to bottom, renal arteries, gonadals, common iliacs, internal iliacs, and branches of the internal iliacs, such as superior vesicle, inferior vesical artery, etc. Okay. So where's the area where there's the least redundancy? So it's really this section right above the pelvic rim, which is kind of the desert, the area of least vascular overlap. So what are, those are some nice pictures, and also what are some of the data about what happens when you mobilize the ureter. So this was a study where they did a pig model, 16 pigs. They assigned them to either having their ureter just transected, so just cut, or mobilized followed by transection. And they placed a oxygen detection probe in the ureter to see what happened to the partial pressure of oxygen. And so on the left side, they're looking just at the UPJ, and the right side, they're looking at the UVJ. So just two different sections of the ureter. So you can see just even when you just cut it without mobilization, you get a small drop, 80 to about around 70 millimeters of mercury. You get less of that at the UVJ for just cutting. But then when you mobilize and you cut, you have this much more significant drop happen. And so that drop in oxygenation is really what is going to be a factor affecting your repair and these aspects of control. So kind of anytime there's an existing guideline on the topic, I think it's important for our trainees to know where the guidelines stand. The urotrauma guidelines were updated in 2020, so fairly recent. And I think they came out after Dr. Grimes' lecture, last lecture here at UW on. So they're relatively rare, accounting for 1% of urologic injuries in terms of like the trauma urologic injuries. Because of its location, we talked about other surgeries and iatrogenic. Also, it's often a source of penetrating trauma as being the source. Injuries may not be recognized early unless they're specifically investigated. So a big part of it is having your index of suspicion quite high, and that's going to be based on the mechanism of injury, the history, etc. And then we'll talk more about the management guidelines themselves. Today's topic really is focusing more on just kind of ureteral injury in general, so it's not purely just the trauma related aspect, but we'll certainly touch on both. So, etiology of ureteral injuries, and I tried to kind of order them in terms of most common to least common. Since the Urotrauma guidelines, when they do this, they do start with an extensive literature search to guide the committee in terms of their guideline statements. So it's always interesting to for residents putting together talks and things like that to look at the references that they include to reach their statements. And in their statements about iatrogenic injury, they refer to this paper here, where they looked at injuries and ultimately what was related to the injury. Here they have a very high urologic surgery as the iatrogenic cause, but they did note here in their caveat that OBGYN was not even at their well represented at their hospital, so it certainly under reports gynecologic surgery. So other papers have listed probably gynecologic surgery as the #1, but I would probably say, given that we are the most common person in the ureter, that it probably is either urology or gynecology as in terms of iatrogenic causes of ureteral injury. Colorectal is also working in the same operative space. So stones and treatment. So probably one of the most common stone procedures that we do are as a specialty is ureteroscopy. And just by the sheer volume of ureteroscopic procedures, there is a small but not insignificant risk of injury to the ureter that may ultimately lead to stricture disease. Here, Dr. Grimes had presented this slide, referring to these papers here, that some of the injuries can be quite severe, as described here, with 25% of patients ultimately undergoing nephrectomy. So remember that next time you're doing your ureteroscopic procedures, that we use the same deal of caution and care as you do with big open surgeries. So talk about trauma is probably the third, because of the location of the ureter. Penetrating trauma is much more likely to be the cause of ureteral injury over blunt trauma. To get to the ureter, there is likely injury to other structures. They're usually higher severity trauma patients with increased incidence of hollow, viscous, and vascular injury. That being said, because of that, penetrating trauma is much more likely to be explored than blunt trauma. So you may be consulted for, during the XLAP itself about the ureteral injury. Going down the list here, radiation as a cause, particularly cervical cancer. Cervical radiation is probably the most common type of radiation that may cause ureteral stricture. Obviously, at least seems obvious to me that depending on the dose, depending on the baseline relative ischemia of the tissue, that the degree of injury or the likelihood of injury will be dependent on the radiation. And then lastly, talk about the last order of interest. I won't really talk too much about it. Is inflammatory and infectious causes. So whether we're talking about retroperitoneal fibrosis, TB, schistosomiasis, as other etiologies of ureteral stricture disease and ureteral injury. Anytime we're talking about injury and healing, I think it's important to just remember that there are 4 stages of wound healing. There are some initial stages that happen relatively quickly, the homeostasis and inflammatory stage, followed by proliferation and remodeling. However, interestingly enough, when really trying to look through the basic science literature of ureteral healing, so ureter specific healing and wound healing, how's that different from kidney healing, bladder healing, et cetera, et cetera? There really is not much out there. Really only could find a few, maybe less than 5 papers on the specific wound healing aspects of the ureter. So this is a study looking at dogs, and they induced an injury, which was this one, complete transection. So that may be certainly different from the mechanisms that we would see in, say, a trauma setting where there might be blast effect, there might be heat, there might be other things that factor. This is purely just transectional. So they induced an injury, they then gave a delay, sacrificed the dogs, and then looked at the content. And the differences between the ureter and other structures, they found that mucopolysaccharide content rises similar to other structures and then becomes normal by 6 weeks. The collagen content peaks at day 14 and then drops to normal by day 21, whereas skin collagen takes months. So the collagen actually tends to proceed faster. However, the bladder reaches normal breaking strength at 14 days. So that might be an explanation why, if we do a bladder repair, we'll leave a Foley catheter for 14 days and then, remove it for Voitrile or cystogram and then Voitrile. The tensile strength for the ureter, at least in this one, even out to 42 days, was really quite low, 1/3 of control levels. So this behooves us that we should really pay attention, because it's going to take so long to build any of the tensile strength, that off tension, the mantras of kind of reconstructive urology is good tissue handling, minimizing tension to the anastomosis, and minimizing infection and things of that sort around the healing process itself, is that even 42 days out, it's 1/3 of control levels. And the end result of all of these injuries is the ureteral stricture itself. So the injury leads to the fibrosis and narrowing of the lumen, as the ureter is the only source of urine transport for that kidney. Obstructive uropathy may develop, and then can lead to potential or permanent upper tract damage and all the sequelae of obstructive uropathy that we're all too familiar with. So interventions are next. I'll kind of divide interventions into acute versus delayed. That's how the Urotrauma guidelines do it. And the first thing I always look at with the guidelines, when they get updates and things like that, is what is the basis for, the evidence for these statements. And in kind of the reconstructive world, for these statements, there is no level A evidence, no level B evidence. The best evidence in any of these statements are level C, so low quality, low certainty evidence. So whenever I make references to articles about efficacy and things of that sort, remember the level of evidence that we're talking about, and then see some expert opinion and clinical principle statements. So the first part is diagnosing the injury itself. You want to know the location, you want to know the extent. So which part of the ureter is involved? Do we say upper, mid, lower, distal ureter? The extent, is it a short segment? Is it a long segment? Is it an isolated segment? The mechanism, was this relatively clean injury? Was this something where we would expect delayed effects to result? And what are the concomitant injuries that we're going to talk about? And remember, these guidelines are the trauma setting specifically. So I will discuss the trauma setting, but I will also, discuss a non-trauma setting as we're talking about ureteral injury much more broadly than just trauma. So here they're talking about, so in the trauma setting, the best study that they feel balances getting the information while minimizing invasiveness to the patient, trauma to the patient, is the CT urogram. So CT with delayed images for stable trauma patients with suspected ureteral injuries. They specifically say that absence of hematuria cannot be relied upon to exclude ureteral injury. So you can certainly look at the UA, but the UA is not a reliable marker for ruling in or ruling out a problem. And like all situations, you want to have a high index of suspicion, like we've said before, about ureteral injury. So even if the patient went through the CT scan and they got a CT abdomen pelvis with IV contrast, but there were no delayed phases, if you have concern or a high index of suspicion for possible ureter injury, you recommend that they send them through again with actual delayed images, those kind of, that kind of thing. So in the non-trauma setting, other ways to evaluate: retrograde pyelogram, ureteroscopy, if the patient is literally, open, methylene, indiocarmine, methylene blue, you can look at dyes, you can, stent, the ability to pass a stent up, or intraoperative inspection. Though they do make a specific statement that intraoperative inspection alone can miss a fair number of injuries. So just be aware of that. The fact that trauma service said, oh, we were in there, we looked at the ureters, they looked fine, when you hear in the morning, does not necessarily rule out ureteral injury, because it can be missed. So CT urogram, you don't always get a 3D reconstruction, but it's just nice for presentations. So in this picture, you can see kidney past, the path of urine down the ureter, and then this hot dog shaped thing, which does not look like the ureter, which in this picture is a urinoma. where it is in relation to the lumen of the ureter, and where it is in relation to the pelvic structures. So this doesn't really tell us the extent of the disease. It tells us where it is, but I don't, with this study here at least, I don't know anything about the distal distal ureter. And at least if this was a purely a trauma study, you want opacification of the contralateral ureter. So this would not be great if all you had for the right kidney was just this sliver of contrast down just to the UPJ. So the considerations are the timing, the mechanism, the concomitant injuries, and the viability of the distal ureter would be factors that determine when you would intervene here. So I mentioned I would just divide the interventions into acute and delayed options. So the immediate things that you can do in the acute setting, you can stent across the injury. You can divert the urine away, such as a percutaneous nephrostomy placement. They say plus or minus ureteral ligation. And that's just to minimize urinoma, etc. You could do immediate repair. Say there was an XLAP and you're literally staring at the injury. You can consider repairing it right there on the spot. And you can consider nephrectomy. That is a reasonable consideration in the acute phase. What they specifically do not recommend to do in the acute phase is it's not the time to do an ileal ureter, it's not the time to do an auto transplant, it's not the time to do a bunch of different heroic measures. And it will depend a lot on what your assessment is of the viability of the ureter, the likelihood of further ischemia to develop, those kinds of things. Now, your delayed options are essentially all the options, right? So now you've let it mature, a stricture has developed, so you can consider a surgical repair. These are the situations that more people will be doing robotic or open. So you can do primary repair, you can do substitution, you can do augmentation, you can do diversion, endoscopic management, nephrectomy, auto transplant, basically all the options. So what about the unstable patients? So the unstable patients, it's primarily damage control. The unstable patient, you're really trying to give priority to the life, to the high risk injuries, which are likely going to be other organs and things of that sort. So stent if feasible, PCN placement, urinoma drainage. You just don't want to spend a lot of time trying to do something that on the order of things that are going to kill the patient, this would be low on that list. So when to consider immediate repair, I actually will talk about a little bit later. So may manage ureteral injuries with temporary urinary drainage followed by definitive management. So should percutaneous nephrostomy be the first choice in all patients? So if you've ever been to any of the national conferences or professional conferences, they sometimes will do these debates where they specifically have a controversial statement and like an absolute, like you should always do this or you should never do this, really to force people to try to take a side in something that really is degrees of gray. So should percutaneous nephrostomy be the first choice every single time you should just place a nephrostomy tube? So here, some of people that I trained with are authors on this article, but what they talked about is one of the advantages of placing a nephrostomy tube and diverting the urine is that it provides ureteral rest. And so ureteral rest is the idea of not having something across the strictured segment itself, which with its small degree of mobility might be actually prolonging the wound healing cascade, leading to never really exiting the early stages of wound healing. And so they're extrapolating from urethral stricture data to apply it to the ureter. And obviously, this is a very select group. We're talking about level C evidence here. So let's just look at some of the numbers they talk about. So this is a bunch of robotically trained surgeons that formed a consortium that they call the or Collaborative Reconstructive Robotic Ureteral Surgery. And so they basically show on the left side, ureteral rest, they tend to get slightly better outcomes than no ureteral rest. And they define ureteral rest as the absence of anything across ureteral stricture for at least 4 weeks prior to the reconstructive attempt. And so when they divide it by technique down there, so let's just say excision and primary anastomosis surgical success, they feel like they get better success at 90% versus 76% with those. Pyeloplasties, which is more UPJ structure, but I also feel like they get higher. They also talk about buccal mucosa graft ureteroplasty, and I'll discuss more about what that is and how that looks. But it's not wrong to divert, just like it's if, like, for example, if you're not comfortable doing a primary repair or re-implant, it's not, the guidelines would support you in doing a percutaneous nephrostomy and coming back to treat it at a later date. This is, these are just some of the other statements. There's only a total of like 12, 13 statements, so it's easy to cover all of them. So assuming you have a stable patient now, you can directly inspect the ureter during a laparotomy. Surgeons should repair ureteral lacerations at the time of laparotomy in stable patients. Should manage contusions with ureteral stenting or resection and primary repair depending on ureteral viability and clinical scenario. This seems obvious, and that's why it's expert opinion and clinical principle make the most sense. But if you're literally looking at an injury and you're staring at it, that might fix it, you generally have the option not to ignore it, and you want to use your best judgment. So you want to assess the ureter, assess the mechanism, assess the extent, and decide based on that. And so this basically gives you all of those options are reasonable to consider in that situation. Okay, so now we'll actually get to the management options. When you talk about reconstructive surgery, you'll get a lot of very creative and innovative ways to repair something. So it's always nice to look at the various options. So, I mentioned immediate acute phase and delayed intervention. So what do we count as delayed? Is 3 weeks delayed? Is a month delayed? Usually we're talking about 2 to 3 months minimum if doing a delayed reconstruction. And that has to do partially with that wound healing cascade and that wound healing timeline. Oftentimes, if they were really injured severely by those other things, by other mechanisms of trauma, you want them to be optimized medically. If they still have a bunch of hardware, they can't be positioned very easily to do your fancy robotic surgery, things of that sort, then there's not a downside to waiting longer with your nephrostomy tube or your stent in place before making a decision on what to do next. So let's start with mid to distal strictures. So I'm not doing UPJ, as that was discussed by Dr. Best. We're just going to talk about proximal ureter, mid ureter, distal ureter. So starting with the mid to distal strictures. They have a statement on it. Surgeons should repair ureteral injuries located distal to the iliac vessels with ureteral reimplantation or primary repair over ureteral stent when possible. So this is the classic ureteral reimplant. There's many different ways of doing a ureteral reimplant. This is some of the evidence of the efficacy, the success rate repairing it. In this study, there was a fair amount of patients here that were more for cancer and things of that sort. But in general, the glomerular filtration rate after a repair does still tend to drop a little bit, but 2 years post-op, but basically stays at least mostly within the the safe stage of kidney disease kind of result. So if like in the blue, which would be benign, your MACE drops from 85 GFR to about 76 GFR, which would be both considered normal. This red one is more acute one. This one dropped from 90 to 70, which both be still over 60 for estimated GFR. So the overall success rate for ureter neocystotomies, which is a fancy term for ureter reimplants, with or without psoas hitch, contemporary series around 85 to 98%. So this is a fairly high success, kind of procedure. And you can see here what a psoas hitch looks like. And this is obviously an open approach with this guy's hand sticking in the bladder. And they did a transvesical and a tunneled ureter, very traditional reimplant. So I think, at least in my opinion, this is probably the most common, standard urologic standard way of doing this, as this is what most urologists in their training are familiar with, feel comfortable with, etc. And this does give you a lot of options, a lot of flexibility. Like I said, people in reconstruction always try to innovate, try to come up with new ways of doing, of achieving the same thing. So this is a paper that I reviewed for the Journal of the Gold Journal, talking about ureteral reimplantation version, maybe version 2.0. And so this one is a non-transecting side-to-side ureteral reimplant. So what does that mean, non-transecting? Well, the idea is if it's involving just the distal ureter, you don't actually completely cut the ureter. Earlier animal studies showed that if you even just cut across the ureter, you still induce some ischemia. So the idea is instead of cutting across the ureter, you just bring the ureter to the bladder, or the bladder to the ureter, and you do a side to side anastomosis of the ureter to the bladder. And so this is kind of like an extravesical approach, side to side anastomosis. The potential benefits is you omit excessive ureteral dissection. You don't need to dissect all the way down. You can stay away actually from the traumatized area because you're not trying to mobilize the damaged area. You're trying to go upstream to the damaged area. So it might be an easier mobilization. You might be able to stay out of the danger zone. And then you get this long anastomosis. And so they described, there are 24 patients across 3 centers, and they said their success rate was 95%, with 6 to 9 months follow-up. And so this is a option to consider. You certainly don't have to do this robotically, but this is what they chose to do. And so I think what you're seeing here, trying to show in the diagram, I think this is the ureter passing, passing here, and this is the ureteral lumen. I don't know if you can see my cursor, but ureteral lumen open here, and then they're going to anastomose it to the bladder there in a side-to-side fashion. Psoas hitch, just some specifics about the psoas hitch. Should psoas hitch be performed every time? It has low. I personally think so. I don't see any reason not to do a psoas hitch. You don't have to go all the way super high on the psoas muscle, on the psoas tendon, but it's low morbidity. Remember how I talked about keeping things off tension? this is a way to keep things off tension, reduce tension on your anastomosis. We already know that the ureter takes much longer to heal than the bladder, and its tensile strength is reduced for a very long time afterwards. So I feel that psoas hitch is generally a good idea. This is a Dr. Grind slide here where he just shows what the cystographic appearance can look like after psoas hitch. You can see this kind of oblong shape to the bladder there. This is a Bowari flap, what that might look like. And let's talk about the Bowari flap. So Bowari flap is a way to get extra length and distance. So here they're saying they're going above the vessels. So you want to make this slightly wider at the base than at the tip. So talk about, ratio of 3 to 1, less than 3 to 1. And what you don't want to do is make this really, really long chimney. At least start off. It might contract down to that, but you don't want to start that way because you're going to produce a lot more ischemia along your suture line. Reflexing anastomosis means you don't have to tunnel. So that might give you a couple more, millimeters, maybe a centimeter distance. And then you just generally want to have a good bladder capacity, be cautious with radiation situations, and understand its implications on continence. So that's mid to distal ureteral strictures. What about proximal ureteral strictures? So proximal ureteral strictures can be either above the pelvic brim or above the iliac vessels, but that they recommend primary repair of ureteral stent when possible. So that can include all sorts of different options. So when possible does give you an out. So if this is not the right patient for primary repair, if chronic nephrostomy tube drainage or ureteral stent drainage is the best option for this patient, then it may be something to consider. So you do have an out, but if you can, if the patient is healthy enough, if they're motivated, primary repair should be a consideration. So ureterostomy. So now we're talking about sewing the ureter to the ureter. So this is a reasonable one to consider. It depends on the extent of the injury. Are you talking about a short segment or a long segment? And how does the tissue look like? What is the viability? So the EAU also has trauma guidelines similar to the AUA. Talk about debridement, spatulation of the ureteric ends, placement of internal stent. So the trifecta would be preserved renal function, no progressive hydro, no long-term stenting. They put UU reconstruction at 70% success rate, and it's more likely to fail if there is malignant disease, radiation, already having baseline impaired renal function, and of the different types of repairs, ureterostomy is more likely to have problems. So not a great procedure, at least compared to ureteral reimplant. So what are some of the different approaches you can consider for these more proximal strictures? So these are some onlay approaches. Here's a augmented approach. So you actually cut out the segment along the dotted lines, and then here they use buccal graft to cover to augment it, and then you have a onlay, and so here you don't cut out any segment, and you use buccal graft, buccal mucosa graft there. And so this is the same consortium or collaborative, the Chorus Collaborative, talking about their results and perioperative outcomes with the buccal mucosa graft. Overall numbers tend to look pretty nice, 87% success rate with the onlay technique, the augmented technique slightly lower. Greater than 6 centimeters, which is quite long. They're quoting 85.7% success rate in 54 patients. So buccal graft, you know, how it's used, where it's used, number of patients. I mean, these are, look at the studies here. Not a lot, you know, not a lot out there. It does tend to be more US focused, since the robot has proliferated more in the US than maybe, say, European countries. And I would say these are in very technically expert hands. So these success rates may not reflect real world success rates. One thing that they'll commonly use is an omental wrap. So in a omental wrap, you'll use the blood supply of the omentum to provide blood supply to the vascular plexus of the buccal graft, because it needs to draw blood from somewhere, and you can't rely on that kind of longitudinal adventitial vascular plexus. I'm right at time here, so maybe I'll fast forward to some of these other ones. So using the appendix, so familiar with Mitrofanoffs and things like that. So this is the idea of using the appendix as an onlay. So instead of, if you have the ureter down here, instead of using buccal graft and putting that in, you can use an appendix that you've now opened and splayed over it. Obviously, it'd be easier for right-sided stricture disease than left-sided. Bowel interposition, recommended against bowel interposition, autotransplantation in the acute setting, delayed setting, all are feasible based on your choices. Remember that there are metabolic consequences to using bowel in the urinary tract. Ileal ureter, it's an option. Long proximal strictures, bilateral strictures. Appendiceal interposition, so going back to the appendix, but this time you're keeping it as a tube, so you're not opening it up along its longitudinal axis. You're keeping it as a tube and basically using it to replace that segment. Nice thing is it comes with its own blood supply, so that's an advantage of that approach. And here, these series, people are doing both left and right-sided. But you see some people do exclusively right-sided when considering using the appendix. And then, you know, single-stage tubularized graft, whenever talking about buccal mucosa, that doesn't work very well. And then you know, limited time, not really talking about autotransplantation, TUUs, and we all know what a nephrectomy does. They do use some caveats for endoscopic injuries. We talked about ureteroscopic injuries. So endoscopic ureteral injuries, first line recommendation is stenting or neph tube. So if you have a misadventure in the OR with a ureteroscope, that's the main recommendations. And then you certainly may manage with open when those initial approaches fail. All right. Last thing, I won't be much longer. So use of indocyanine green. So this is basically talking about that one of the advantages of the robot is that it has this near infrared fluorescence, which we can't see with the naked eye, but you can use these things to better identify the ureter. And it's used in two main ways. They either use it to inject in the lumen, which is one way to better identify the ureter for dissection. And then the other way is to give it IV to identify the blood supply. Remember, there is one caveat to that. If you inject it in the lumen, you can't then turn and inject it IV because it tends to stick to the mucosa. So it'll confound any interpretation of those results. So like I said, one of the most challenging parts of doing ureteral surgery is finding the ureter. And this is one way to help reduce that part. So this is how it looks. Pretty pictures in green, what a repair might look like. And so the challenges are there's poor understanding of ureteral wound healing, long strictures tend to have worse outcomes, and possible tissue engineering approaches may be the future. So urethroplasty should use early management of ureteral. I keep saying urethroplasty, I meant ureteroplasty. And thank you. I think Dr. Nakata had mentioned that moving to a different position from UW in a few months, and I want to say thank you to all my colleagues and trainees for my time here at UW. I did not have the question thing open, so maybe I'll get to that segment here. But I know I'm over.
Thank you very much, Brian. I think we do have a few minutes for questions or comments for Dr. Lee.
Thanks, Brian. That was a great comprehensive talk. And I think one of the things you mentioned both at the beginning of the talk and at the end of the talk that's critical is the challenge of identifying the ureter. You know, often if you're called in, you've not done the dissection, you've not set up the retractors, and you just got to find the ureter. My trick has always been I go to the iliac artery. You know that the ureter is going to cross the iliac vessels. The iliac artery is reliably, identifiable because of the size in the pulse. So incising the posterior peritoneum right at the iliac artery, and then looking there, often more medial than you think it's going to be, is the trick I've used. Are there any other tricks that you have, or for example, laparoscopically, you mentioned that the dye?
Yeah, so yeah, different ways for identifying the ureter. So we have a couple tricks up our sleeves as urologists. You can put something in the ureter, like a 5 French open-ended catheter. So oftentimes, if you put it in, you can feel it, right? You just if it's open in an open case, you can feel it. You can pass a ureteroscope. You can see the light from the ureteroscope often through the ureter. It doesn't travel very far, so that's why the indocyanine green is actually better than just the light. And remember, if you have a digital scope, the light is not strong enough to be able to see. So digital scope won't work as well doing that. And also, when you're passing the scope in, you'll see this almost like this, wave-like tunneling thing moving up towards the area. And so that if you're looking in the right spot, you should be able to see that. But yeah, like you said, oftentimes when you come in that scenario, you're not the one that set up the field. So the first thing to do is just, kind of understand where the things are, try to break out your bag of tricks. But those are different ways. So you can either by palpation, you can put stuff in the lumen, are all techniques. And then obviously anatomically, using your knowledge of the anatomy.
Hey, Matt Grimes here. I was just going to add, you can inject the neph tube too if they have a nephrostomy tube. That's bailed me out a couple of times when I'm struggling or trying to decide where to transect.
Yeah, and the ICG thing where they're doing the intraluminal dye, they usually will inject nephrostomy tube from above and below, especially if it's obliterated.
Yeah, I might add too, for robotics that the using the light from the ureteroscope can be really helpful. I've started putting a ureteroscope up on most pyeloplasties just to get facile with that, and it's pretty cool because the white light fluoresces under the infrared, under the firefly, so you can see the ureter. It just starts glowing. It's pretty cool.
Yeah. Other questions?